This is the November 2023 MEC Minute, and our topic this month is going to be CPAP and BiPAP. We're having this conversation because we're going to transition to a new device from our existing CPAP device to a new device that provides BiPAP, but could also be switched over to CPAP mode if needed. So I thought that before we start rolling this device out, we have a conversation about CPAP and BiPAP to bring everybody up to speed to the change and why we're making it. So we're going to talk a little bit about why we're moving to BiPAP and the BiPAP device. We're going to compare and contrast the physiology of CPAP and BiPAP. We're going to talk a little bit about when CPAP is indicated versus indications for BiPAP. I can give you a quick summary right now. The bottom line is we're going to start our patients on BiPAP, but I'll explain that later. And then toward the end, we've got about a 15, 16-minute video from Lieutenant Jones showing how to set up the new device. And I would like to thank up front him as well as his 3 children for participating in this training episode. So come the first of the year, we're going to transition to a new device. This is a portion of it. It's a device through which we can deliver either CPAP or BiPAP using a mask and so on. And it really, I think it's going to be to everybody's advantage, particularly our patients. This device, you can adjust the pressures. You can use your standard oxygen cylinders and actually use less oxygen than you're currently using with the CPAP device. It's got a manometer so we can measure our airway pressures and make adjustments in the device as necessary to maintain the inspiratory and expiratory pressures that are going to be delivered by the device. As part of our process, we have been giving advance notice to the EMS coordinators. Hopefully, your departments will be running out of the CPAP devices at about the time of the first of the year. If not, if you have leftover CPAP devices, you can use them up before you transition to the new device. So during that period, if you do that, you'll have to maintain proficiency with both devices. So what is CPAP versus BiPAP? So both of them are positive airway pressures. In other words, you have a device that's putting back pressure on the airway. So CPAP means continuous positive airway pressure. It means you have a constant pressure of 5 centimeters of water, 10 centimeters of water against the patient's airway. And what it does is it reduces alveolar collapse. If the patient's having trouble with secretions in the airways or in the alveoli, it'll help expand the alveoli. If there's some that are open and some that are collapsed, it will help recruit some of those collapsed ones to open up those alveoli and reducing the amount of atelectasis. So CPAP gives respiratory support, but it does not augment respiration. So it splints the airways, it keeps the airways open, it improves oxygenation, but it doesn't help the patient breathe better. So CPAP requires that the patient has adequate respiratory drive, and what they need help with is oxygenation. BiPAP, or bilevel positive pressure airway, or airways pressure, gives pressures on inspiration and expiration. The expiratory pressure, which is the back pressure when the patient exhales, is similar, if not identical, to the constant pressure that CPAP delivers. It's when the patient inspires, there's an extra pressure kick that helps the patient inspire and move air in. So what happens is CPAP improves oxygenation, whereas BiPAP helps reduce oxygenation or improve oxygenation, but it also improves ventilation. It helps the patient breathe more easily. And it also helps reduce the patient's CO2 level in their airways. So CPAP will help with oxygenation, BiPAP will help with oxygenation, but will also improve ventilation and improve exchange of gases and reducing the patient's CO2 level. So it provides respiratory support. It improves oxygenation and reduces carbon dioxide levels. And that's the key difference between the two. So how do we look at this? Here's the pressure waveform. If you look at the bottom line where it says 0, that's if we have no CPAP or BiPAP on the patient, there's no back pressure on the airway. At 5 millimeters of mercury, see the red dotted line, that is what a CPAP pressure would be. Typically, we start a patient on CPAP at 5 millimeters of mercury. I'm talking about centimeters of water. It's 5 millimeters of mercury. I'm sorry for the confusion. Whereas if the patient inspires and they're on BiPAP, they get some additional pressure delivered, and it'll drive their airway pressure up to 15 millimeters of mercury. That helps increase their respiratory efforts, helps them breathe more easily. So it assists with respiration. The difference between the 5 and the 15 millimeters of mercury is considered the BiPAP driving pressure. That's that pressure that helps move air into the airways. So we're going to go back to CPAP a little bit just because it's a good starting point. CPAP is an effective way to treat heart failure and COPD. It increases the functional reserve capacity. What is the functional reserve capacity? That's the amount of gas, or the volume gas, remaining in the lungs at the end of expiration. So CPAP helps keep those alveoli open. It keeps the airway open. It increases the volume of gas in the lungs. It keeps the alveoli from collapsing, and by keeping the alveoli open, it improves the surface area that is available for gas exchange. It's just like if you have a balloon. If it's deflated, there's not much surface area to the inner or outer surface of the balloon. If you blow it up till it's full, you have increased surface area of the balloon. So if you look at that as one of the alveoli, if it's got a bigger airway or a bigger surface area, there's more surface area for gas to cross. More oxygen get into the blood, more carbon dioxide can come out of the blood. So FRC has helped. And then it increases patients' O2 sats, and it'll hopefully decrease the need for intubation and associated mortality. So again, improving oxygen, what also happens is when you have this pressure on the airways, it increases the partial pressure of oxygen, which means there's more driving pressure for oxygen to go from the airways and into the blood. And that is a good thing. So it improves oxygenation. And also, if you think about it, the oxygenated blood, the blood that's in the lungs waiting for gas exchange, it has a lower partial pressure. So oxygen is going to flow from the area of higher pressure to lower pressure, another way of getting oxygen into the blood supply and oxygenating the patient. What is BiPAP? Well, BiPAP is like CPAP. I mean, it improves oxygenation. It has that back pressure at its lowest pressure rating. It's at 5. With inspiration, it'll go up to 12 or 15. So it helps the patient get air in. It assists with ventilation, and it's an effective treatment for hypercapnia or CO2 retention, or for those patients who have mixed respiratory failure where they can't oxygenate and they can't get rid of CO2. So we call that hypoxemic hypercapnic respiratory failure or mixed respiratory failure. So these patients have to have spontaneous respirations, but we're helping them. And typically they also, we want them to have evidence of CO2 retention, so we want to offload that CO2. But it's really not that easy with our patient populations. We can't tell sometimes if the patient's just purely hypoxic or if they have some hypercapnia. So for our patient population, if they're in respiratory distress, if they tolerate a mask, just start them on BiPAP. It's probably the better of the two treatments, and they will do well. We'll get them to the patient, get them to the hospital in improved condition. We've done our job. So more on what to use when. Again, we see that oxygenation pressure curve at the top, with the driving pressure. Patients with expiratory pressure or EPAP, which is another way of saying CPAP, that it improves oxygenation. It will help treat heart failure. What CPAP does is doesn't just help oxygenate this patient in heart failure, but it also helps increase the intrathoracic pressure a little bit, which reduces the amount of flow of blood to the heart so the heart doesn't have to work so hard. So it tends to be most effective in patients with heart failure or hypoxemic respiratory failure or atelectasis, airway collapse, alveolar collapse. And the risk for the patient for CPAP or EPAP is impaired in exhalation. They can't breathe out against the positive pressure. And if you have too much of this EPAP pressure, the expiratory pressure, you may be limited how much positive pressure you can give the patient. Now, for patients who are going to benefit from the driving pressure or BiPAP, in other words, of calling BiPAP as driving pressure, it provides mechanical support for breathing, it improves ventilation, it increases tidal volume, there's more air moving in and out of the lungs, which is going to result in better gas exchange, both oxygen and CO2. It seems to work well with those who have obesity, those who have respiratory failure because they're starting to tucker out, patients who have neuromuscular weakness, so patients who have some of the neurological conditions like Guillain-Barré or some of the other conditions, it may help them. And complications is if you increase the tidal volume too much, it can result in barotrauma. In other words, you can cause a pneumothorax. And too much driving pressure can limit the amount of expiratory pressure you can give to the patient. Another way to look at it again is CPAP is for patients who can still do the work. BiPAP is for the patients that need help getting the work done and have hypercapnia. Again, my position is if the patient's respiratory distress, start them on BiPAP, let the hospital sort out next steps. By using these devices, we have done a lot over the years to reduce the number of intubations in the field. So again, some contraindications to the devices and maybe some predictors of success. Patients cannot be in cardiac or respiratory arrest to use the device. They have to have some respiratory effort on their own. So if they're not breathing, they need to be bagged and then intubated or have an I-gel placed. If the patient's hemodynamically unstable, particularly if they're hypotensive, I mentioned that these devices may reduce venous return to the heart. Well, if you put too much pressure on them, you could actually aggravate their hypotension, so be careful. The patient has to be able to protect their airway and to clear secretion. So if the patient is actively vomiting, if they have a large amount of sputum production or nasal secretions, they're not a candidate for the device because the mask will prevent them from keeping their airway clear. We also have a problem with patients who are uncooperative or agitated. Patients who's agitated is not going to keep the mask on. There are times we will sedate the patient, and I'll talk about that in a minute, but generally if the patient's flailing, they're not going to tolerate a mask for CPAP or BiPAP. And then if the patient has some deformity of the face, whether it's because of recent facial surgery or they have that face that no mask is ever going to fit, or if they've had significant maxillofacial trauma with an unstable face or bleeding or any other impairment to mask fitting it properly, they're not a candidate. So who might succeed? Those patients who have the ability to cooperate. We have some patients who come in and say, I need CPAP or I need BiPAP. Patients have a good fit, have no air leak. Patients who have some evidence of CO2 retention, but it's not severe. But they also have some ongoing respiratory effort. Patients who have moderate acidemia, in other words, their pH on blood gas is less than 7.35. That's really not something you measure in the field, but you can get an idea of what their CO2 level is based on your capnography. And then predictors of success also have patients who improve in the first 2 hours. Hopefully we don't have that patient for 2 hours, but we generally see substantial improvement in our patients even during the 15 to 20 minutes you have them under your care receiving CPAP or BiPAP. So indications, again, COPD and asthma, good candidates. Patients with pulmonary edema, like this chest x-ray on the right shows, where you see the fluffy markings of the lungs. Patients with acute respiratory failure for any other reason, it could be from some patients with overdose or neurological conditions, or some people just starting to tucker out because they're breathing so hard. Patients with pulmonary infections, COVID, an easy example. We've all been through it. A lot of our patients with COVID were supported with CPAP and BiPAP. It kept them off the ventilators. A reasonable number of patients also failed non-invasive ventilation, but we gave it a try. And patients with ARDS, acute respiratory distress syndrome, may benefit. And then again, patients who drown, patients who have other insults to the lungs, could be a chemical injury or some type of inhalation injury. CPAP and BiPAP often is very helpful. Contraindications, again, respiratory distress or respiratory cardiac arrest, agonal respiration. So if the patient's having 6 respirations a minute, they don't need BiPAP, they need an airway. Facial deformities, severely depressed level of consciousness. Again, patients have to be able to maintain an airway. If they have severely depressed level of consciousness, intubate them and get things taken care of. Hypotension, signs and symptoms of pneumothorax. We talked briefly about barotrauma, all this pressure into the lungs. If the patient has a pneumothorax, they should not be put on BiPAP or CPAP. It can actually turn a simple pneumothorax into a tension pneumothorax, so be careful. Inability to maintain an airway is a contraindication. Trauma, closed head injuries, chest trauma may be a contraindication. It depends on the circumstance. Patients who have vomiting, again, if they're vomiting and they can't maintain their airway, they shouldn't have a mask placed. And then any airway edema. So if you have an inhalation air injury with thermal burns to the face, CPAP, BiPAP, contraindicated, they need an endotracheal tube. Complications, pressure sores. We shouldn't see that on our patients because pressure sores typically occur when the mask has been on for hours and hours. Our turn times are much quicker than that. We mentioned a complication of aspiration. Sometimes there can be gastric distension. It's just like when you bag a patient. If you put enough pressure on the airway, some of that may go down into the stomach and you get gastric distension. A big swollen stomach can impede diaphragm movement and make respirations more difficult. Eye or sinus irritation or injury can be an issue. Sometimes, again, barotrauma to the chest or the lungs with pneumothorax can be a complication. Sometimes we can blow off so much CO2 that they actually become alkalotic, and that's an issue. Sometimes patients may just stop breathing on their own because we're doing all the work for them, and sometimes anxiety can be provoked by the device in the mask. So, one of the complications we think about is claustrophobia. It is common, but don't give up. Let the patient hold the mask. Let them put that on their face. When they start to feel better, they realize the mask is helping, and they may be more welcoming to the procedure. And then at a point, you can put the straps on the patient. If the patient won't tolerate the mask, don't force it on them. You're not gaining anything by doing that. We also can use some gentle sedation. I like to use a little bit of ketamine, mostly because it's the least of the depressing in terms of respiration of the other medications. So midazolam and fentanyl are more likely to depress respirations. The other advantage to ketamine is it also seems to have an effect on improving bronchospasm. The downside to ketamine is it tends to make patients have a little bit more oral and pulmonary secretions. But any of these medications can be used to provide some gentle sedation for patients with trouble dealing with BiPAP. I would start small and give more if you need it. So what does all this mean in terms of the 2024 protocol? Well, we are going to have a revised protocol that's been updated in terms of how you utilize the device, how you set it up and turn it on, but it's going to be a single protocol for adults and children, so the adult version and the pediatric version go away. We're going to have just one protocol and it covers everything. And then, again, as I mentioned earlier, our agencies can use up existing supplies of our CPAP circuits before transitioning to BiPAP. That's something that needs to be coordinated through your EMS coordinator or whoever manages your supplies. So now it's time for a video. I'll pause for a minute. We'll insert a video for you to watch, and then I'll come back with a quick review.
Hey everybody, thanks for joining us. We're going to go over the new CPAP circuit that we're going to at the beginning of the year. As you know, the old CPAP circuit, a lot of moving parts, especially on the pediatric side. This video is tailored to pediatric, and the reason it's tailored to pediatric is because there are a couple of new things we are doing on the pediatric side, including the bi-level mode. Now you're going to hear me talk about bi-level and BiPAP interchangeably. It is the same thing. BiPAP is kind of the proprietary, and bi-level would be the generic, so kind of like Tylenol and acetaminophen. So what we're going to do is we're going to go over the new setup. We're going to go over bi-level treatments a little bit, and at the end I want to put it all together so it kind of makes sense, we hope. Alright, so currently the packages you have come as a kit, and inside that package you have the mask, you have the capnography, you have the medicine bowl as well. So the new package is going to be mostly the same, it's just going to be the setup is different. What do I mean by that? You're not going to have the white adapter, you're not going to have the blue adapter, you're not going to have multiple size masks in the same bag, and you're not going to have the sizing chart. So that's kind of like CPAP for Kids 1.0. This is going to be CPAP, BiPAP for Kids 2.0, and I think it's going to be a lot easier, and it's going to be a lot friendlier for everybody, and I don't think people are going to be quite as hesitant about using it. I know there were a couple of times over the past couple of years, after the run was over, the thought process was, boy, maybe I should have actually used CPAP. Maybe this brings it down to a level where everybody's more comfortable, and we can move forward with that. Alright, so you guys know about the old CPAP unit. This one's going to come together kind of like this. Going to be your aperture, This is going to be the mask, and inside each package you will have a medicine bowl and a T-piece. So yes, we are kind of using the old breathing treatment bulbs just because we need an inline breathing treatment. And so we're going to use the same thing we used long ago. So when you open up the package, you'll have the capnography. That's good. You'll have a mask, one of 3 sizes. There's an adult large. Then there is a medium or small child. A medium or small adult. And then there's going to be a small child. Now what I want you guys to understand is large adult, it's large adult. We're not too concerned about that. Again, this is the pediatric side, and we're going to focus mainly on the little people, right? So when you get the package, understand that it doesn't matter if it's for pediatric or if it's for adult, the package is exactly the same. The only difference in the packaging will be the size of the mask for the patient. All right, so let's talk about BiPAP just for a second. You're going to have 2 new pressures that you probably haven't messed with before. Some of you have, some of you haven't. You're going to look at IPAP and EPAP. IPAP is the inspiratory pressure. So when we're on CPAP, that's always, for argument's sake, 5 centimeters of water, 7.5 centimeters of water, or 10 centimeters of water. That's always constant, blowing in your face. It doesn't change. That is IPAP. Okay, so as we're getting ready to put the device together, we have the IPAP and the EPAP. The IPAP is the inspiratory pressure. The EPAP is the expiratory pressure. Now on this device, it is very simple to go to CPAP, which everybody is used to, and then transition to BiPAP or bi-level if the call indicates. That may not happen every single time, and you're obviously not going to use a breathing treatment every single time, but I want to make sure you understand how simple it is to go from CPAP to the BiPAP mode. On the end of this device is a green switch. It is labeled CPAP bi-level. It is nothing more than a turn of the switch, and you go from CPAP mode to bi-level or BiPAP mode. When you do this, you'll be able to adjust the expiratory pressure when you're in bi-level mode with the dial on the side. You will see EPAP plus, EPAP minus. All you have to do is turn the dial until you get the manometer to the correct pressure, correct setting. This is your IPAP. This is how you adjust your EPAP. So, for our protocol, we're going to have 10 over 5, so 10 centimeters of water every time we inhale, and every time you exhale, it's going to drop down to 5 centimeters of water. That way we can blow off the carbon dioxide, bring down the capnography just a little bit, and hopefully make for a better outcome for the patient. So when you have it in bi-level mode, you want to take it up to 10 centimeters of water when you inhale, and when you exhale, it needs to drop down to 5. And to adjust that to the correct pressures, you use the dial on the side. Now you might ask, well, how do I know where to set it on the oxygen bottle? It's very simple. Every single device, every setup comes with this blue chart that is wrapped around the oxygen tubing. This is bi-level mode, and it tells you the flow rate and what the centimeters of water will be on the IPAP. If you flip it over to CPAP, again it has the flow rate on this side, and on the right hand side it has the centimeters of water, what you should be able to expect. Now, here's something that we have all found out, that not every flow meter is created the same. So what we found out several months ago is that just because it says it's flowing at 10 liters a minute doesn't necessarily mean you're getting 10 liters a minute. To overcome this issue, what we have found to do, just turn up the knob to the next regulated rate. So for some of you it might be 12 liters a minute, it might be 15, it might be 20, whatever the case is, just go ahead, turn up 1 notch or 2 notches. That way you can get the regulated pressure that you're looking for. Again, we found this out just because not every flow meter is created the same, and after a while they actually don't flow as much as what they're rated. So we found that to be an issue. I wanted to pass that on, that way if there is any question, and there will be, that's already taken care of. Alright, so how do we assemble this product? And again, it doesn't matter if it's adult or CPAP, or child. It's all created the same. It's all put together the same. If you're going to BiPAP mode, I'll switch this back to, to CPAP mode. I'll switch this back to CPAP. You'll have your capnography underneath of it. Now this is a small child. Obviously, if you put it on an adult, it's going to be bigger. That's it, folks. It is that simple. And this is for child. And guess what? The only difference between this and if you're going to do an inline breathing treatment is you're going to add the inline breathing treatment bulb. That's it. So there is no longer the blue adapter, the white adapter, the elephant trunk, the card sizing chart, or multiple size masks. This is it. So what we're going to do real quick is we are going to show what it looks like on a kid and why not every mask is created the same, but you'll have that option with your EMS coordinator, and that'll be up to you guys. Come here for just a second. When you are sizing this, now this is an 8-year-old, okay? So obviously it's still in the pediatric range, but it's also the small adult or medium mask. So what's it look like? On the outside you're going to have a single seal, and on the inside you're going to see another seal that's just a little bit smaller. So what's that going to do? That's going to create a more correct seal placement. So go ahead and step right here. When you're putting it on, it's just like the other head nets. There's nothing special about it. It's going to slide right over the face. Now this one's kind of been pre-sized a little bit already for him, so it's kind of cheating maybe, but that's okay. Well, you know what? To adjust it, just like some of the old CPAP masks, Velcro, you pull it tight until you have a good seal. Same way on the other side. Pull it tight until you have the proper seal. Oh, getting your ear in there, sorry bud. Alright, so that's kind of what it's going to look like. Now what you can't see in the video is those two inner seals. The outer seal is fitting him pretty well, maybe just a scotch big, because you can see where it's starting to come over the eyes a little bit, but it has that inner seal. That inner seal is just under the mouth, so it's right at the chin level, and the inner seal is also right over the bridge of the nose. This should create a good seal for this this age. All right, I'll take this off of you, and now have a seat. Thank you, sir. Come here, honey. Have a seat right there for me. Okay, now. This is a 2-year-old. Our protocol states that we can perform CPAP or bilevel for kids 1 year of age and older. And again, the contraindications or the precautions are pretty much the same for a child as it's going to be for an adult. So if you have a facial anomaly or facial features that don't meet the mask requirements, obviously you're not going to use it, right? All right, so this is a small child. We're going to put it just like that. And again, turn your head just a little bit, and you'll notice that the outside seal is just a little bit big for her, but the inner seal, which you guys can't see very well, is right over the bridge of the nose, encompasses the chin. It should be a fairly decent a seal as well. So if we need to adjust it again, it's the same way. You hook it up on either side, and you can adjust it with the Velcro straps. So this should be a decent size and a good seat for a 2-year-old. And for this 2-year-old, her facial features are actually a little bit smaller, and that's why it's a good model. That way when you have your 1-year-old, there's a chance that, especially an older 1-year-old, it's going to fit the small child just fine. Thank you, my dear. All right. So now what we need to do is we need to put the whole thing together, right? Just like on the old CPAP units, we have an oxygen source for the main CPAP unit, and then we have an oxygen source for the breathing treatment itself. So come on over here, please. We've already pre-sized this for this guy. So the mask goes on. It clips in. Turn your head just a little bit for me, thank you. All right, so look over here. Can you open your eye? There we go. All right. Beautiful. Now right now we're just going to do CPAP. You ready for it? Alright, so we're not going to do any breathing treatments or anything like that. This is CPAP mode only, and for our protocol we can start at 5 centimeters of water. We can work up to 7.5 centimeters of water if we need it. For demonstration purposes, we're not going to do that. I'm just going to kick it on a little bit so you can see what it looks like when it's running. I don't know if you can hear it or not in the video, but I can tell you right now that this is not nearly as loud as the current system we're using, that long, expandable, elephant trunk looking thing. Much quieter, and it's running off a small oxygen source. A small oxygen source like this is going to last 5 times as long or more than the old systems. Why? Because it's using so much less oxygen. So the interesting thing is our old system, it only gives you a maximum of 30% FiO2, and it doesn't matter what centimeters of water pressure you're giving the patient. It's a flat 30%. This can give up to, depending on respiratory rate, depending on the setting, up to 100% FiO2. So we're reducing the oxygen consumption, increasing FiO2, and if we need to increase the centimeters of water, we can do that as well. All right. So that was CPAP mode, right? Right. Now let's do a breathing treatment. Now you'll notice CPAP is the only time you're going to do a breathing treatment according to the manufacturer. The reason I'm doing this is because I want to show you that yes, the manufacturer says that you need to do it in CPAP mode for an inline. However, here in a minute we're going to show you that it can be done in BiPAP mode as well if something happens. All right. Ready? All right. Turn on the oxygen source for the breathing treatment. Now, I don't know if you can see it very well in the video or not, but there's a kind of a cloud coming out right here, right? So on the old units right here, right there, if you go out and look in your truck right now, would be the old anti-asphyxiation valve. On the new units, it's actually at the end real close to this green knob. All right, so the breathing treatment's running. We're going to go ahead and kick on the CPAP part of it. And again, I'm not putting it at its highest rating. It's not needed. All I want you to see is that you can see the condensation in the mask. He's getting what he needs. This is where we need to be, right? So right now he's actually under 5 centimeters of water, but like I said, we're not doing the full therapy. All right. Now, to go to bi-level mode, all we have to do, flip a switch. That is it. It is that simple. He is still getting medicine as is needed. The manufacturer recommends not doing that, only in CPAP mode, but he still does get the recommended amount. Okay. Now finally, before we call it done, I'm going to show what this looks like in bi-level mode and what it looks like on the manometer and how to adjust it on the EPAP side. So we're going to hook it back up. You ready? All right, I'm in bi-level mode right now. I'm going to turn it on. All right. Beautiful. All right, so I'm going to turn you sideways. Now what I want you to see, and I hope everybody can, is every time he breathes in, there we go. Now every time he breathes out, then breathe out. Notice how the dial drops, right? So when you're breathing in, our protocol is going to be for pediatric 10/5. Every time you breathe in, it will be 10. Again, I don't have this up to the highest where it's recommended for the pressure. And every time he breathes out, it's going to drop. That way it's easier for him to get the bad air out, and when he breathes in, get the good air in. It's that simple. And if you want to adjust the dial on the side, that's all you have to do, and it changes your inspiratory and expiratory settings. That simple. That's all you have to do. The hardest thing will be adjusting it per patient when you're on the run itself, but it is that simple. And again, as we found out, not all flow meters are created the same. You may have to adjust up in order to get the recommended amount. I hope that answers a lot of the questions. I know it's kind of new for some folks. Other people have already been through it. If you have any questions, please let us know. Thanks a lot, guys.
All right, thank you, Lieutenant Jones. In conclusion here, just make it real quick for wrap up. CPAP and BiPAP are effective treatments for respiratory distress. We have already seen that with CPAP. We're adding BiPAP to the mix. CPAP is good for hypoxia. BiPAP treats hypoxia, but it also supports respiration and helps the patient eliminate CO2 from their body. For most of our patients, just start with BiPAP and don't worry about the CPAP. That's all I have for now. Thank you. If you have any questions, please reach out to me or your EMS coordinator. Thanks again.